Yes.
Okay. Okay. So this is a picture of the cardia just like the other one, and it shows a single lead ECG. This bit here is where you put your fingers. I've even seen one trace where it was actually done on a Labrador puppy when they managed to get the paws on, and it produced a very nice trace. But that's not always the case, and I wouldn't recommend it for use in veterinary care, but it does work. The first case we've got is a little chappie called Raphael. He was 6 years old when he first presented in April of 2018 with a very racing heart whilst he was running. And the GP saw him and found him to have an irregular pulse and did an ECG in the outpatients there, and it showed atrial ectopic. So that's what the report said, although I never actually got to see the ECG. A referral was made to Leeds, and the fact was that we felt probably that the ectopics were benign. If the child was otherwise okay, there were no other signs, it probably didn't need any further follow-up. But just over a year later, he represented with 4 episodes of palpitations with his heart rate of 245 on a pulse oximeter. And it's interesting, really, because it's quite common that parents turn up now and they say, oh, there was a fast heart rate and we put the oximeter on and it was 245 or 275. And one also has always got to say to them that they're not always that reliable, these little finger pulse rate monitors that you can get for about 15 quid off Amazon. Well, when we saw him, we sent him off and we did a Holter ECG, and it showed that his rate varied between 54 and 195, and he had some isolated non-conducted P waves, which we didn't worry about, the occasional supraventricular ectopic, which is very usual. And there are 12 patient episodes. That's where they press the button on the Holter device and it marks the recording, but only one symptom reported, and that coincided with normal sinus rhythm. So after this, we're saying, well, you're not having very frequent episodes, so let's give you one of these new AliveCor devices. So we got that in August. In February 2020, he was still getting palpitations, getting 1 or 2 a month. We'd not picked up anything of note on his AliveCor recordings, but the episodes only lasted 2 to 3 minutes. Again, Mum was saying that we picked up ones, 270 on his pulse oximeter, but nothing on the AliveCor. And at that point, he was seen in the outpatients, and he was said, well, no, we could think about doing an EP study, although that's a bit heavy-handed, or maybe even putting a Reveal loop recorder in. But they elected, let's just carry on for the moment with the AliveCor. A few months later, he activated his device a few more times, and actually the automated interpretation came up with atrial fibrillation. And what I've included here is the email that Mum sent to us to go along with this recording, and it says heart readings in between very short fast heartbeat episodes, 5 seconds each time with a 1 minute gap in between, and we couldn't capture it in time, so we took a recording as soon as we could, by which time it had finished. But the instant analysis of both said possible atrial fibrillation. Not sure, not the issue we're actually trying to capture, which is the possible SVT, so thought we'd send it anyway. And this illustrates a very common theme, really, isn't it? That no, they miss it. They can't get it in time, and it turns up with a automated interpretation, which is not quite right. But we persevered, and Mum persevered. And a few months later, she sent in further recordings. We still haven't managed to capture one of Raphael's episodes yet. Still possible. Supraventricular tachycardia only lasts 1 to 2 minutes, and by the time we got the device and the app opened and switched to the right Wi-Fi network, the heart has gone back to normal. We'll keep trying though. I'm determined to capture it. And perseverance was very important in this case. But it does illustrate the point that it does take time. You've got to get the device out, you've got to unlock your phone, you've got to activate the app, you've got to go through the bits and pieces that tell you, do you want to upgrade your app to the more recent version, all this sort of stuff goes on. And then you finally make recording, by which time it's gone. And that it takes time. She did persevere, and in August 2020, which is way beyond the 4 to 6 months people were saying maybe you should give it for that long. So if we'd given it for 6 months, we'd have missed all this, but had a narrow complex tachycardia, 202 beats per minute, which coincided with 270 beats per minute on the oximeter. So it just shows that was a bit wrong, wasn't it? And it only managed to catch the last 15 seconds. So we could have missed it, another 15 seconds later, and that would have been it. We would have missed this episode, but we got it. And this is the episode shown here. This is the tachycardia here, and we actually capture it breaking. So I've blown this off, and we can see the narrow complex tachycardia up here, and below it, we can see it come back into sinus rhythm. So a very sudden offset of tachycardia from a rate of 202 beats per minute, and we banged it to rise. So very useful, but way beyond the 6 months that you're talking about. In fact, a matter of a year or so, almost 2 years, in fact. So at that point, we were able to give them options of, do you want to go on drug therapy? Do you want to try some ablation therapy? Or shall we just wait and see what happens? And they actually opted to do nothing. And so they've kept the device, and if they get more episodes and they become more troublesome, there's a possibility to go back and then reassess the options. But very useful. Amelia is the next case. She was 10 years old and had a family history of ARVC, or arrhythmogenic right ventricular cardiomyopathy, which is associated with sudden collapses due to ventricular arrhythmias. In 2018, she presented with chest pain and funny feelings in her chest, but not true sort of SVT type palpitations of the sudden onset and offset. She had a normal resting ECG done, very important in somebody with ARVC, and had a normal echocardiogram. She wasn't sent to that stage for MRI scanning in view of her family history of ARVC. We did 24-hour Holter ECG. Unfortunately, the leads fell off, and so we only had 7 hours of that, but it showed a normal sinus rhythm throughout, varying between 67 and 127. And she then went off for an exercise test. She managed 8 minutes with 2-minute truncated stages, and there was nothing abnormal on that. So the feeling was, no, the chest pain was probably nothing, normal ECG, normal echo, normal tape. Let's just see how you go, see you in a year's time, as much for the ARVC as anything else. It was just over a year later she comes back, and she's now saying, actually, I'm getting palpitations now where my heart's jumping out my chest, and these can last anything from 20 seconds to a minute. She had a repeat 24-hour Holter, during which she did have a mini palpitation, and that coincided with a single ventricular ectopic, so nothing too exciting. Because these episodes were fairly infrequent, the feeling was, well, let's go with an AliveCor. And so she got given her AliveCor just shortly after that appointment, and started then sending recordings in, and we had 1 in June, we had 4 by November 2019, and all of them showed sinus rhythm. And so we're thinking, oh, this is somewhat reassuring, but we're still not there yet. January 2021, still getting palpitations, has all her ECG repeated, her exercise test repeated, and that's fine, although she did get a bit of hypotension after stopping exercise, which is not that uncommon a finding actually, but nothing related to arrhythmias or anything. And again, a Holter ECG done with 1 ventricular extrasystole, but no symptoms. So, no, okay. All out of the blue. So 2.5 years after having her AliveCor sent to her, and 3.5 years after she first presented to us with the chest pain and possible palpitations, she turns up with a very clear narrow complex tachycardia, again with a sudden offset, and she managed to capture the last 20 seconds of it. So again, not too bad. They did well to get there. But if we'd given it 6 months, we would have missed this. If we'd given it a year, we would have missed it. So I think there is an argument in perhaps even leaving some of these patients with their device long after 6 months, if you've not had something definite. No, definite symptoms, we're sure we caught them, and this is what it showed. She was starting on atenolol because of the SVT, and she's currently awaiting an ablation. And the consideration also is that when she's asleep having her ablation, should we slip in a Reveal loop recorder for future use? More so not because we're worried about recurrence of SVT, which is possibly not to 10%. We're more worried about, could she develop problems related to her ARVC in the future, in which case, because that's often syncope, the symptom, using the AliveCor isn't going to be as useful as having something that's going to be recording her heart rate all the time, but very useful. But yeah, 2.5 years after having her device given to her. The third case is Alfie. Now, I actually a little bit involved in Alfie as well, actually. It goes back a bit. So he was 10 years old in November 2016, was referred with palpitations, and he had at his local hospital a documented SVT at 220 beats per minute, which I never actually got to see. It's one of those things where it never quite got across, but I believed what I was told. And the history was very good for palpitations in this young 10-year-old. And so I just listed him for ablation and ablated him. And that was carried out in May 2017. And what we found, we could induce superventricular. Oh no, shouldn't have done that. Hang on. So what we could see was we could induce supraventricular tachycardia rate of 210 beats per minute, which was nice, and that it was very similar to the rate that was seen when it wasn't under anaesthetic of 220 beats per minute in the clinical situation. And it was related to what we call a concealed pathway in the middle of the heart where the little red blob is. So I'm hoping here. So this is the coronary sinus os here, this is the tricuspid valve here, and we found that we had early activation just at this point when we were stimulating the ventricle. So the electrical impulses were coming back up into the atrium through that point where the pathway was. And I ablated that, and initially it was a bit nervous because now it's very close to the AV node and the risk of heart block. And I did get some prolongation, the first degree heart block, and that recovered during the course of the procedure. But after the ablation, we couldn't see any further inducible tachycardia. But when I gave adenosine, I could still see evidence that there was some retrograde conduction, not through the AV node, but from somewhere else that looked to be very close to the AV node. But it wasn't the AV node because we'd blocked it with the adenosine. We couldn't give much more adenosine though, because he had a bit of a nasty asthma attack because of it, and the anaesthetist wasn't keen to give anything more. So what we thought, we couldn't induce any tachycardia. We've seen what we think is the clinical tachycardia. Let's leave this one alone rather than risk damaging his AV node and then got with a pacemaker. So that was May 2017. So October 2017, we're seeing him in clinic. He's still getting occasional brief palpitations. His PR interval's at the upper limit of normal. So we stick him on the treadmill and just make sure he can conduct normally. And he goes 1-to-1 at 200 beats per minute. So he's got good AV conduction, even though his PR interval is a little bit at the longer end of normal. Still getting palpitations a couple of years later, only every few months. And so what we did in July 2020, we gave him an AliveCor, saying, see if you can capture something, because we don't want to go back if we don't need to and think about ablation again. So a couple of months later, he sends in a recording when he had his palpitations, but it looks normal, 130 to 140 beats per minute, clearly not the SVT. January 2021, which is now quite a bit after he had his AliveCor, again, a number of tracers sent in, all of them normal. So we're thinking, oh, maybe it's nothing, maybe he's just experiencing a sinus tachycardia, but let's just wait and see what happens. So in fact, we're already, 6 months in, aren't we now, from having his AliveCor, really? April 2021, so quite a bit later, he gets palpitations and he sends this in, and he's got narrow complex tachycardia at 245 beats per minute. We're bang to rights on this. So again, 6 months, probably too short. In May 2021, my colleague, me having retired, took him back to the catheter lab, couldn't induce any tachycardia. If you remember, we couldn't induce a tachycardia related to this second pathway at the time of his previous ablation. But what it showed was that it concealed mid-septal accessory pathway. So the previous short circuit was here, and this one was further up. And we know it's different because when he tried burning around about here again, it did nothing than induce some heart block. So it involved going a bit higher up, getting very close to the AV node. And again, there was an issue with conduction through the AV node anterogradially, but that improved. Although the Wenke back cycle length by the end of the procedure was only 100 beats per minute, that meant he started to Wenke back at 100, which is quite low. So clearly you weren't going to do anything more after that because of the risk of inducing complete heart block. But we now go back sort of at least 6 months afterwards, and he's got no more palpitations, and that's clearly enough. So I think when people were talking about, how should we be employing these different tests? Well, if you look at this, what I've done is I've sort of come up with the different options we've got, the different therapeutic options and what have you, and sort of judged them by how they might be helping us. So the 12-lead ECG gives you the best quality possible for a tachycardia, but the chance of actually picking one up is unlikely. So I've had it happen twice to me in 30 years that somebody's come into clinic, told me they were getting palpitations, said, oh, they've started, I've got them quickly around into the ECG room, and we've got a 12-lead ECG of them in tachycardia. But we can't rely on that twice in 30 years, can we really? It's very cheap, so it gets 5 stars for a cost because it's very cheap. No good at picking onset and offset because you're never going to really be able to pick those up. You can use it in any age. Good for palpitations only if they're happening at the time. So generally, if you've got somebody with palpitations doing a 12-lead ECG, whilst it might show that there's a Wolff-Parkinson-White type pathway, it's not going to be helpful otherwise, really. And it's no good for looking at syncope, really, other than if you're looking at PR intervals, long QT, and things like that. And the success of 12-lead ECG is not going to be that useful. Holter ECG, either for sort of a day or 3 days or 7 days, the quality is actually very good. The cost is not bad. It's good at picking up the onset of the tachycardia and the offset, which really does help us distinguish sinus tachycardia from an SVT that we'd want to be treating. And also can give you some further indications of the type of tachycardia it is as well, whether it's an atrial tachycardia, an AV re-entry, or an AV nodal, what have you. Good for palpitations and good for syncope because it's on their recording for the entire time the monitor's on. But the success rate for it is not that brilliant because the chances of you getting an episode of your symptoms when you've got the monitor on, if they're happening quite infrequently, means that the chance of picking up something are sometimes quite remote. There's 2 types of event monitor. There are ones like the AliveCor, which I call mobile. So this is something that you've got in your bag. There's nothing physically attached to the body all the time. You get a quality of recording that's not bad, and I've got some recordings to show you. The cost is actually very good because it's cheap. It's a bit cheaper than a Holter, we're going to say, so it gets 4 stars rather than 3. It's not so good generally at picking onset and offset. For onset, by the time it's come on, it's going to take time to get the machine working and getting your recording, so it's not very good for that. For offset, you might be lucky, like we have in those 2 cases, where it just so happens that the episode's been short, but just long enough so that it could be picked, and therefore we've had a recording of 30 seconds that runs into the recovery time as well. You can't use them in very small children. What's the age that a child can use it? No, it varies. You certainly will be okay in 10-year-olds and above. I think trying to employ them in little babies, I've certainly wanted to do that in a baby. We couldn't get it to work with mum, who is actually a consultant. Because I think what was happening was that the mum has to touch the fingers, which then destabilizes the ECG. So that's a bit of an issue. So you need to be able to really do it yourself to get some really good recordings and stay very still. Good for palpitations, no good for syncope. How can you get the machine out if you're actually unconscious? And of course, by the time you've recovered to do the recording, you're going to not have the tachycardia anymore. Success, actually pretty good, very good. For success, it's only really beaten by an implantable loop recorder. The quality of the recordings in the loop recorders is excellent, better than the event monitors, but not as good as the Holter perhaps in certain cases. Cost is quite expensive. You're talking, over £1,000 for the device itself, and then there's the cost of putting it and taking it out, and the cost of sending traces in and having somebody look at them. It's good at picking up onset and offset because the way the recorders are set up is that they can activate, and you can set it up to remember X number of minutes before they activate it, or alternatively, it can do it automatically as well. And they're very clever, these machines now. So it's very good at picking up onset, and it's very good at picking off offset, and it's good for any age because you can put it in almost anybody, and it's good for palpitations, and it's excellent for syncope, and the success rate is pretty universal. I've never had one that haven't given us an answer, but it's more expensive. I've put in permanent pacemakers and AICDs at the bottom, but haven't really filled the boxes in, because of course these devices will record intracardiac ECGs throughout. And so in fact, if you've got somebody with palpitations who's got a device like that in, we're going to get intracardiac electrograms showing us what's going on. So that's our options. So I still think there's a good case for using Holter ECGs in many of the patients, if only as a first step sometimes. 12-lead ECG, this shows a big difference. So this shows there's a right bundle branch block actually in a patient with a repaired tetralogy fallow, and this shows a ventricular tachycardia. And it's only because we've got a 12-lead ECG that we can be sure that this QRS complex is so different and that has all the hallmarks of being VT. If this was a single lead ECG, it could be very difficult. But no, this is pretty lucky. This is the classical Holter ECG. It's done from a while ago. It's a 2-lead ECG, this one produced, and this was somebody who had had syncope. And there's about a 23-second pause in this. It actually runs from this point here, which is just off screen here, all the way down through, and then we start getting some electric activity of some use back here, and that works out, and these are about 8 seconds each, so it's about 24 seconds. That wouldn't have been picked up on an AliveCor because they were clearly quite unconscious by that stage. This child grew out of this and did very well, in fact. This shows a reveal download. So this shows, these are subcutaneous electrograms, of course, and this shows a tachycardia, an SVT that's jumping in and out. So here it's running and then it stops, it picks up again here, and then it stops again. There's a ventricular ectopic here, and then it runs again. So in fact, this tells us a lot about what's going on, and this would be very difficult to pick up on an AliveCor. You'd be hard pressed to be able to pick that up and get a good tracing. So the quality of these traces is actually very good on a reveal. Sometimes, interestingly enough, the reveal is very good at diagnosing epilepsy. And this is a child who's actually referred to me with recurrent collapses. And I was pretty sure this wasn't going to be cardiac, but no, the neurologists were pretty sure this wasn't going to be neurological. And so we put a reveal in them. And this was one of the episodes that the child had when it had its fit. And we can see that it develops a little bit of a sinus tachycardia, which increases, which is good to see in somebody who's having a fit. And then there's all this electrical activity here. And then this bit, which I've expanded from here, we can see there's clonic muscle activity interspersed with an ECG. Interesting enough, they weren't quite happy with this neurologist to make a diagnosis of this, so we had to wait for them to do it again, and we had the same activity again, and they said, yep, it probably is a fit. And they were treated for fits, and we subsequently took the device out. So it's not probably the best way to diagnose epilepsy, but it can be quite useful. The parents were made up by this, actually. They were very happy. iWatch recording, somebody mentioned, what about them? So this is me. And I was trying to get one when it was going really fast and see if it could work well. And I'm quite careful. I wet the tip of my finger. I'm very careful to touch the end of the watch so it picks up properly. But no, in sinus rhythm, it's fine. Now, that probably is a sinus brady. I'm running probably about 50 beats a minute there or something like that, but I'm a bit slow. Well, not my heart's just slow, everything's slow. This is a sinus tachycardia. I'm only running at about 130 beats per minute here. But the quality is not bad. But at times, this is what it's showing. Now, when it's showing this rubbish rhythm, which looks like a horrible ventricular fibrillation come tachycardia, I was actually perfectly well, but you wouldn't have known it from that, would you really? And that's me trying to get a good recording. So they're not that good. And I've been quite disappointed by iWatch recordings, to be quite honest. Although I don't think Apple would agree with me. At other times, though, you can get good recordings from the cardia. So this is me. I have an old device that's returned to me. So this is one of the earlier generation cardias. when they were, I think, £79 plus VAT. And you can get actually quite a nice recording from this, and it shows sinus rhythm with a nice P wave, QRS complex, T wave, so very nice. But it becomes more difficult when it gets much faster, and it becomes more difficult when you start moving around as well. So